Good afternoon and good evening to all of you joining from around the world. On behalf of the organizing committee of Sigvaris, I am delighted to welcome you to today's MOH Medical Online Hub Connect, hosted on our Medical Online Hub platform. Today's session, Intervention for Revascularization of Deep Vein Thrombosis, the best practices, innovation, and international perspectives, brings together leading experts from Asia, Europe, and Middle East to discuss one of the most complex condition in venous intervention and its role and the role of compression. We are especially honored here today to be broadcasting live from the state-of-the-art Dr. Rahul Jindal Clinic in India, a unique center committed to advancing patient outcomes and multidisciplinary collaboration. Today's program showcases a powerful fusion of Indian, German, and Egyptian expertise, just as you wanted it, learning from each other and pushing the boundaries of care together. At Sigvaris Group, our mission to promote global scientific exchange, and we invite all of you to be a part of the conversation. Please use the Q&A and the chat box to place your comments, your questions at any moment of time, and we will try to address most of them during the panel discussion session. I am Dr. Darshan Mehta, and I have the honor of moderating this session. I'm truly looking forward to the knowledge, innovation, and inspiration that we can get from the distinguished speakers today. With that in mind, it is my great pleasure to introduce our principal moderator, Dr. Mohammed Omar El Farouk. Allow me to share a few words about him. He is a consultant, vascular and endovascular surgeon with expertise in advanced endovascular and open practices for critical limb ischemia, diabetic vascular care, and complex aortic aneurysms. He is also specialist in hybrid techniques for PVD, varicose veins, and dialysis access. He completed medical degree in Ain Shams University and vascular surgery training in UK's West Midlands rotation, earning fellowships from both the Royal College of Surgeons of England and Edinburgh in 1994. He currently serves at the General Organization of Teaching Hospitals and Institutes in Cairo. Dr. El Farouk is very active in surgical education, simulation, and skills training, and has published many papers throughout his career. He also serves as an examiner for the Royal College of Surgeons of England, and we are very happy to have him here with us today. Over to you, Dr. El Farouk.
Thank you very much, my dear Dr. Dashan, for your kind introduction. I'm really pleased today because we have two of the world famous stars, not just in venous intervention, but all vascular manipulation. They are eager to spend their time to give you a wealth of experience of their vast amount of knowledge and tips and tricks. Let me start with our star, which is Professor Erica Mendoza. She is specialized in venous intervention, and she is one of the greatest advocates for Shiva procedure. She is also authorized, have multiple authorized books on duplex scan for Shiva in Springer in Germany. And she also provides lecture and hands-on, and we have enjoyed her multiple times in our MOH webinars and MOH workshops. She is General Secretary of German Society of Phlebology since 2015. She is the President of German Phlebology and Lymphology Society, and she is multiple in so many societies with very active participation. I really enjoy every time I see her in a meeting and lecture. And our biggest star, which will do the live case, is very dear friend, Professor Rahul Jindal. I thought for many years that he's venous man, but actually he is both arterial and venous man. He done so many arterial intervention, and he is specialized in endovascular surgery. He worked in Fortis Hospital. He has been building over the last 25 years, great experience, has done multiple workshops, both in India and in multiple Middle East countries as well. And he has vast arterial and venous intervention. I can go on and on for multiple hours. He also have his FRCS degree from St. Mary Hospital. So he's already practiced so many new innovation in venous intervention, and I can go on and on for what is his achievement, and I'm sure we all benefit from him. And very dear thanks to Dr. Dahshan, who has studied a homeopathic medicine from Mumbai and later an executive MBA in healthcare from esteemed India School of Business. He is a consultant education manager. He's very welcome to MOH Active Hands-On. And he is an expert in market at Sigvaris, and he's also owner of the Lab Medical Healthcare. I would like to welcome him on board, and the mic is to you, Professor Erica Mendoza, to start introducing the case and to go to Jindal after that. Erica.
Thank you. Thank you for the introduction. I just have to correct, I'm not the president of the German Phlebology Society, but Shiva Society, but okay. I was in this workshop last year with Rahul, and I have to recommend everybody of you just to join in there. You learn so much in 2 days, in 3 days. It is astonishing. It's so well organized. It is a wonderful team he has around there. And I was surprised about the lot of increase in knowledge I had there. And we have to say that Rahul is vice president of the UIP also, and he's very engaged in teaching. And now stopping with blah, blah. Rahul, would you like to start presenting the patient, or shall we go in starting doing things
sure.
and you present on the go? How do you want to?
Sure. I'll start the presentation.
Yes.
The presentation is very brief, and can you hear me well?
Yes, perfect.
Okay, first of all, really, thank you. First
Yes.
of all, really like to thank Erika for joining us last year. You were a great asset in the workshop, and we really enjoyed you having this last year, and we are going to miss you this year, really.
Okay.
And Mohammed, thank you for being a friend for such a long time, and you have been really very helpful, in making a lot of my friends in the Middle East and especially in Egypt. And thank you, Darshan, for joining up. And he's going to demonstrate live compression stockings on these patients once we have complete the interventions. So I'm really very happy and delighted that Sigvaris and Medical Connect has given us an opportunity to present a case here. We really wanted to present you the state of the art latest acute DVT interventions with penumbra flash devices, but unfortunately we couldn't arrange for an acute DVT case because the patient was not well, so we had to operate day before yesterday. So, but we have kept another very interesting case for you. It's a chronic deep venous obstruction case. He is a middle-aged man who had a deep venous thrombosis on the left leg few years back, and he came to us few months back with a C6 venous ulcer on the left leg. So we did a conservative treatment on him. We have been able to heal the ulcer very well, but you can see he still has got a lot of pigmentation on the left leg. So we did an MR venogram on this patient, and we found that there is a diffuse disease in the SFV common femoral vein, and there is an occlusion of the left common iliac vein. So this is not an easy case to present in a live case, but that's what the real world is. So we have kept here one of the very complicated cases. So let's hope we are successful in the end. But this is what we are going to do. Now, why we are doing this intervention in this patient is because patient is symptomatic. He has got venous claudication. He had a recurrent venous ulcer, and he has got a lot of swelling in the leg, from which he is symptomatic. And he has got some inflow from the profunda and the SFV to warrant an intervention. So we, in terms of classification, so this is a case, if we are successful, we'll be able to give him the very good results. So I have got Dr. Munir with me here, and we got the staff of the vascular staff. We got Dr. Piyush Chaudhary.
We would love
here.
to see them, Rahul. We don't see them.
Yeah, Dr. Manir is here, and Dr. Piyush, Dr. Piyush is here, Dr. Aditya, Dr. Hussain, and so they are fellows here. And we got Mithil here, we got Navjot, our sister in charge, she's here around. And yeah, she's here, and Mithil is here. So, so we got a lot of people out here in terms of who are helping us in this, and all the IT team and the digital marketing team, and so they are all here so that we can promote the education program. So, so we can start with the case if you are okay.
Yes, please change to full screen for your, yes.
Yeah.
Thank you. I'm very happy you're presenting a difficult case because this is real life.
Yes. Okay. Thank you. And just bear with us. And so we got these three machines. So we got a German machine with us, Rega. So we got Zeem's Advanced Vascular Intervention CM, and we got Samsung Vascular Ultrasound with us out here. And we got an IVUS from Boston Scientific. We have put in out here. And so all the three machines is a routine thing what we use when we do the deep venous interventions. So the plan is to puncture the calf and the popliteal vein. So what we have done is we have already put in a 6 French sheath just 10 minutes before, and into the right calf. We have put the patient under general anesthesia so that he does not hear us. What we
Sorry,
are doing.
You said into the right calf, but you're treating the left one. You want to come from
No,
above?
we are putting in the left calf.
Okay.
Sorry. Yeah. So we put in into the left calf.
Yes.
And so, and now the plan is to do the venogram.
Yeah.
And then see what we can see out there, and what is the intervention, so we can discuss, and how should we proceed further.
Can the camera show the introduction sheath? Because yes, from the other side.
Can one of the cameras be here, please, on the sheet? Can I have the flash?
Okay.
Flash and the contrast.
Don't. It's okay. We can imagine.
No. Please, we should be able to show you very clearly.
The camera showing the leg is not sharp. It is too.
Yeah.
And this one goes into the saphenous vein, or where does it go?
No. We have punctured the gastrocnemius vein.
Okay.
I'm just going to show you. Just hold on. Can I have the ultrasound picture? And so this is where we are. So this is the sheath. Our sheath is going here. You can see very clearly.
Yes.
And so what we have done is we have punctured the gastrocnemius vein because this was very prominent.
Yes.
And this was going directly into the popliteal vein. So we are going to take the angiogram and show you. So can we have it over here, right, please? Come.
Please change the ultrasound to the angiogram.
Yeah, so you can change the ultrasound to an angiogram. So they are very good. So they will be able to change it immediately. So ultrasound, radiation on, please. Okay, can I have the collimation? And can I have the machine over there? This machine's here. This is the problem we face, you know. इतने सालों से मैं किया हुआ है ना setup. इसी reason से किया.
The popliteal puncture, Erika, I can do it supine or prone position.
Yes.
Which one do you prefer? I started to prefer supine position lately.
I prefer prone position. I mean, the looking down of the patient. But I think you can do, if you're an expert, you can do any.
Yeah. So we actually used in 2006 and 2007, we used to do prone because that's what we were taught. And I think 2009 we shifted to supine. So after that we have never done actually any prone. Because it's very uncomfortable for it's very uncomfortable for the patient and for everybody. So we can see very bad deep veins here, and you can see a lot of synechias, old DVT changes, chronic DVT changes in the popliteal vein, superficial femoral vein down there, and very bad changes in this area. Can we go up,
And
please?
the second vein is the profunda, or which one?
Yeah, it must be the collateral which goes to the profunda vein.
Yes.
Yeah. Up, please.
I'm sorry,
up,
I have to correct you. It is not called the superficial femoral vein,
Yeah,
but just femoral
yeah.
vein after the.
Yes.
But
Now there is the new terminology. Now it's
I
not.
can understand you use superficial because you have to differentiate from the profunda. Yes.
Yeah.
Yes. But yes, please,
You
Sarika, correct
you
me.
may say it as you want, just for the audience.
No. Please correct me. So we're just taking another angiogram in the proximal thigh, and we can see the preferential flow into the deeper aspect, and of course there is some flow. There are a lot of syneche inside. We can easily see. It may be very difficult to cross, but we'll see how we go. So this is another picture. Can we go up, please?
Can you do bolus chasing imaging, which is available in the new techniques?
Sorry.
There is a bolus chasing software that
Yes, there
will
is a
chase.
bolus changing. Yeah. So the problem is here when we do the complex cases, we use the other cath lab, but in the theater we don't have these facilities to do that. So otherwise we can actually do all in one go.
Okay.
Absolutely.
So we've
Absolutely,
now
you're right.
seen that the profunda femoris was filled much quicker than the superficial one.
Yes.
Or say the same from the femoral vein. This was very
And-
interesting. And now this is the profunda vein.
Yes, this is the profunda. And then later on, the SFV is filling up, and there are a lot of collaterals in the pelvis out
And a
there.
filiform, just filiform iliac vein, I think,
Yeah.
I guess.
Yes.
It is like.
Yeah. This is the problem.
So-
When you inject the dye, usually you go to the easiest way, which is the profunda, and you don't have information on the femoral vein,
Yes.
what happened.
Yes.
I usually put a catheter to be in the femoral vein and then inject in it. So this will tell me the story of the femoral vein up to iliac. But sometimes if you inject, all will go to profunda and you haven't really got the information that you want.
Okay, understand. And this one is.
Okay, so we are doing this, and hopefully we should be, because there will be a delayed filling of the iliac veins, and so there are a lot of collaterals.
There is a filiform, just very thin, possible iliac vein rest there.
Yeah.
Yes.
So we can see with lot of collaterals, the IVC is getting filled up a long way. So what we are going to do is we are going to puncture the right common femoral vein also, so that we know where the IVC bifurcation is there, and so it'll be much easier for us. And we are given 5,000 international units heparin now to the patient, so that we don't have a problem. So I'm just going to show you this right common femoral vein puncture. Or can you have an ultrasound, please, on? So that's so basically we do the transfers, so we can see the common femoral vein, common femoral artery, and then we.
It's surprising that it is so large, because in the it just looked thinner.
Yeah. So, but I'm doing it on the right side now.
You are going from the other side. Okay.
Yeah. So why we are doing it? So that we have at least some access to the IVC junction where it is, so that we don't have a problem.
Yes.
And that's the plan. So I'm going to puncture the.
Is the venous vein?
Yeah. Long
this is a venous vein junction. Yes.
And I'm going to show you a bloodless technique which we use in our clinical practice. So we just puncture the needle, and then put the wire, guide wire in. Can you have the camera here? Is the camera out there? Can you see it?
Yes.
Yeah. So we put the guide wire beforehand, and then we take the vein puncture out here, and we do and this, and then we put the guide wire inside. It's all ultrasound guided, of course. And we go into the deep femoral vein. So there is not huge amount of loss of blood from the common femoral vein, what we have. And we will put in a 7 French sheath on the right common femoral vein, so that we have an access at least to where we are, we will want to know. And
Can you just show an ultrasound image of the left side groin?
sorry?
Could you just show an ultrasound image of the left side groin?
Yeah, sure. I'm just going to do it. So can I have the scissors, please? Ideally, we drape the common femoral vein left side at the same time, but we knew because this patient has got a lot of iliac disease. So let's see the common femoral vein on this side, and can I have the depth, please? इसके ऊपर लगाया नहीं पता, platform लगाओ. So that. So that's the artery here. That's it.
Yes.
That's it.
And there is lots of material inside the vein.
Lot of material is there, and if we look in the longitudinal direction, we'll be seeing much more bad things.
Yeah.
And so that's an artery here.
Yeah.
And that's a vein, and you can see a lot of muck out there, which is there. So let's hope we are able to. Profunda looks good, but the
profunda is
femoral
going
vein
down.
is not very good. So let's try to cross this lesion if we can. And we have kept a safety network here because when we reach at the top, we may require an access where the IVC junction is, so that it is much easier to cross. Can we have the machine down here in the knee side, please?
IVC juncture is internal.
So we bilateral common iliac veins, we want to where it joins, because there is a left common iliac vein obstruction. So it is sometimes very difficult to find where the junction is, where the wire is going. Is it going into the collaterals? So sometimes very difficult to know. So down here, please. So as you can see, it's not a straightforward case. And laser on, please. Who is doing it? Yeah, up, forward.
Would MRV venogram show you where is the IVC bifurcation?
We already know.
Related to bone marrow.
Yeah. So we already know about it. But I think when you do it intraoperatively, then sometimes you need to direct the sharp cannulation. That's it, Pish. Yeah. And sharp cannulation, then sometimes it's not very clear. So I'm going to use the roadmap technique so that it is much easier for me. And so let's make the roadmap. So I'm going to use a very simple simple catheters, right 5 French right Judkins catheter, coronary catheter with a straightforward aroma wire, which is like the glide wire. It's a hydrophilic wire which we use, and so let's hope we are able to cross the lesion. So I'm going to. So we have already reached the. So we have already reached the popliteal vein. So let's see where we go, future, because it is going to be now. The difficult time starts now, and so we have crossed a little bit. So let's hope. Okay, go up, please. So
it looks so easy, Rahul. How many years did it take you to be so expert? Looks like going and
up. So we have reached the profunda area. So this is here we reached. Up, please.
And do you feel much of resistance?
Yeah, a little bit, but I was rotating the wire while I was moving it. So up. So this is a good sign because we were able to cross. That's it, Pish. That's Pish. I need to tip of the catheter. That's it. Okay, so I'm going to take another run here and take the wire up.
So the technique you are using is first making the venogram, leaving it in as a contrast, and then you see that your catheter is moving up the correct way.
Yeah.
Yes.
So stop, please.
There are some of us that didn't do these things earlier, and so I'm trying to understand properly.
So I'm doing the venogram, making a roadmap.
Yes.
And so life becomes much easier rather than trying it blindly, because the better sometimes we got very nice machines nowadays, and so we have.
Now I'm looking forward if you go inside this.
So now I'm going through the external iliac vein. Very difficult. Lot of
it went inside the. Really tiny.
Yeah. So it's a very,
Congratulations.
very, very tight now.
Yes.
And so, but we are just trying to push up. Let's see. And let's go up.
Actually, yeah, I think he crossed an occluded segment of
Yes.
the common femoral artery, because what we have seen is the collateral flow from the side branch,
Yeah.
but he did actually pass. This was a nasty occlusion that sometimes we use CTO wire and we use a supporting catheter and a telescopic system, and sometimes it doesn't pass, it just perforate. But he done it very beautifully. I totally agree. He is very experienced. I
So
think he
let's see
crossed
this.
1,000 of these.
He was lucky today.
Yes.
No, he's
Ariga,
excellent.
absolutely. I totally agree with you because uh, it should go
No,
well.
I can know the
It's a
movement
live
of
case.
the wire if you are lucky or an expert. You're
Okay,
an
can I have the
expert.
roadmap, please? So what I'm seeing is here, there are a lot of collateral. So your wire can actually, it's a glide wire. So your wire can actually go anywhere. So what you need to do is focus. I'm just focusing on that beak, which is there absolutely at the junction. And I'm also, I know the anatomy goes into this form, but my catheter now has refused to move. So, so it's not moving. So many the support catheter. Yeah, need support catheter. So, so I'm now going to change the thing. I'm going to park my vein because my catheter is not moving now. 0.35 support catheter. So I'm going to change my policy. I'm going to keep the wire. I'm going to remove the catheter because this catheter is not going out, going up. It's very, very tight. So there are two ways to do it. So one is I'm trying to get me a balloon. 4 French, 4 or 5 ka balloon. 6. Okay. New. So I'm going to make a way. So what I've done is I've taken a 6 mm balloon here, which I'm going to go and which we have prepared. And so we didn't know this. And Mani, hold the wire, please. So we are going to go and make a way so that my catheter goes up. So I'm taking the balloon up there. Let's see, my balloon also is not going. Wire is coming back. So it's very, very tight. So I'm going to do one inflation here because the balloon is stuck here somewhere. It should have gone up. It's not going. Can I have the inflation, please?
You
10.
recognize the balloon by the black spot.
Yes. So there is a black spot here.
Yes.
So I'm not going to remove my roadmap because I need it.
Yeah.
So I'm doing this. I know it's in the femoral vein. 10, please. Deflate. So I just did the inflation so that because there may be a synechia somewhere in the common femoral vein by which my catheter is not going up. So I'm trying to do this up, and so that the balloon, I'm deflating the balloon. So I'm making a way up because the balloon is very glide. It's much more glider than the
Oh, wow.
than the catheter. It should go up much easier, but even if it's not going, it's very tight. Okay, 10, please. So I'm inflating it up to 10 millimeter mercury.
Which type of balloon?
So this is it's an Abbott. It's a balloon from an Abbott. It's a 6 mm balloon diameter, and it's 120 or 150. 120. So it's a 120 balloon, and deflate, please.
Okay.
So you gained like 2 centimeters or 3, correct?
Yeah. So I'm just trying to move 2 centimeter up, making a way up and going up because I need to guide my wire towards the IVC. And for that, I need a catheter which can rotate and guide my wire. I don't want to put in blindly because it is in the collateral now, looks like it's not in the right path. So it may burst one of the collateral and cause a bleeding there. So I'm just, my balloon also is not going up. So let me see. Okay, inflate, please. Yes, look for a 4 mm balloon.
And could you make sure where you are with ultrasound, or are you sure you aren't? It looks like a very straight vessel. Why do you?
Yeah. So I'm actually in a vessel which is very clear, and like let's say what you are saying is maybe just hold on.
It's a very nasty occlusion. It's really very, very difficult.
Yeah.
It can take hours to pass such an occlusion.
Yeah, it may still take hours.
Yeah.
We have just
One of the tricks is that to use the straight end of the wire or the back end of the wire, but
Yes.
it is
So
dangerous
at
because
present,
it is.
the problem is not the crossing the wire. Wire has crossed. The problem is the lesion is too
Too strong, too hard.
too strong. Where
Yeah.
my so that's my balloon.
Yes.
So that's my balloon.
And it
Yeah.
is in the iliac vein.
It,
In
it
Yeah.
is in the iliac vein.
Internal
So we
iliac
can,
vein.
yeah, it's in the iliac vein.
Yep.
Deflate, please. So so let's try. So if it doesn't go, so then I'm going to cross, try to pass a smaller wire, smaller balloon, and but I'm thinking that slowly and slowly I will make my way. We have already come at the bifurcation of the common iliac vein, I think, and slowly and slowly you have to just be very patient about it, and sometimes it doesn't go. Then we change the wire into an 18 wire. Okay, inflate,
He's also
inflate.
using the hammering technique for the wire, which is
Yes.
multiple pushing in and out. This is very nice technique for passing venous occlusion. This is very
Yes.
nice.
Deflate. And so I'm just making a way a little bit. There are a lot of methods you can use. I can put in a longer sheath, put in a stiff wire, put in an 18 gauge wire, put in a smaller balloons, inflate, make a way. We'll see. If we are not going to go with this, then we are going to change one after the
Okay.
another,
Do,
different
do you have
techniques.
do you have a preferred tool for a nasty occlusion, like CTO wire, for example, or
Yeah.
something like that?
Yeah. But if required, yes. But at present, we are not able to cross. So let
Yeah.
me try. Can I have the new stiff wire, please?
And just a stupid question, perhaps could you try and meet it from the other side, from above to from the internal inferior cava vein down inside the?
Yeah.
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 But that's the last technique.
Okay.
We come from the top and try to enter here, but that will be the last option. If
Okay.
I'm not able to,
Okay.
if I'm not able to grow. So what I've done is I've just
No, it
put
looks
in,
great. Not?
yeah. So I've just put in my fifth wire here and
Excellent.
You
Excellent.
balloon up.
passed the lesion.
Yeah.
Yeah.
Excuse me if I ask these silly questions because I'm not used to see this.
No, please, absolutely.
So
He actually passed it very,
so-
very nicely. He didn't loop.
yes, this
and
is a
then
large balloon. Okay, wonderful.
Exactly.
But are you in
So-
the caval vein? Okay, no, you aren't still, or are you?
No, I'm not. No, it's still there, still up. Okay, wire out, please.
I think maybe
So
a
now-
couple of centimeter up, he will be in
Yes.
IVC.
Yeah.
But
So
this
now
is
what
usually the most nasty part.
Yes.
So
And
we have been able to cross a bad part, which was stuck up. We were stuck up. We were not able to cross. So now what we are going to do is we're going to take a run on the right side and see where my thing is. So I know where it is. You can see very clearly. So can I have the roadmap, please? Yeah. So I'm going to make this as a roadmap, and then contrast. So on
This
this, I'm
technique,
going
he
to
will
use.
know how far away he is
Yeah.
from IVC.
Now I know how far I am. So now I'm going to use the contrast and also in center. So on the top of that, so now I know where I am, what I'm doing. So we got still a long way to go, and because this is the worst part of the lesion which we have to cross. So we are going to try to cross with a softer wire now, and so let's see if my balloon goes a little bit further. Otherwise, I'm going to use the catheters now after this.
Would you think injecting a bit of RTPA with a bit of saline diluted will help you in passing this occlusion?
Yeah, not with the saline because it's a very hard occlusion. So, but I'm just trying to cross little bit. And okay, inflate please 10. Okay.
This is very good technique.
Wow.
How meticulously, yes. He is just getting enough pushability by dilating the part that he already passed. So now the lesion is not sticking to the wire. Now there is free space, so his pushability is moved up. And this is done by multiple time. You can see he's progressing maybe 1 millimeter every minute, but it is in the right direction with very safe technique. It's really Really excellent technique, Raul.
Yeah. So we'll put in, now we change, because my balloon is straight and my wire is not going towards that direction. So I'm not going to change it because my catheter was not going before. So now because we have done the ballooning, maybe my catheter will go up, because catheter can help me in changing the direction of the wire, because wire is going in somewhere collateral, which I don't know. So now my catheter goes, can you see, quite high up.
Yes.
So now I can take, I know where I am. Can you transfer the picture on the other side? Yeah. So we have taken where the map is. So now I'm going to take another road map from this. So to know, so this is not very good. So it is a difficult one, because you can't see the path anywhere. Anyway, we'll have to try blindly. So okay.
Sometimes I use a trick to put the patient, to put the C arm on the lateral view, because the iliac vein at this step is having a curve. And I put the wire on the normal vein, which is the right side, and I try with the left side to follow the same direction, because usually in AP view doesn't give you this information, because iliac is
Yeah.
very tortuous. But there are multiple techniques to be used.
But here you see, here you see the indwelling behind the artery, correct?
Yes. So I think you are absolutely right, and that is one option which we are going to
Wow,
use.
you're going, you're
And
passing.
yes, so I'm trying to see if we, because this is the lesion which is hard. I think I have already reached there. I'm seeing it on the other image, which we have already using it as roadmap for us. And so I'm going to bring my stiff wire here again and take my catheter up, and stiff wire, please. So I'm going to use my stiff wire here again, so that I can move my catheter a little bit up. And
What type of a stiff wire would you use, Raul?
we are using an amplas.
Amplas, okay.
Yeah, this is with a 10 centimeter floppy tip. So
Not the super stiff, but the stiff wire.
no, just a stiff wire.
Yeah.
Because I'm just using the 10 softer part of the floppy tip there. If it goes up, and if not, then I have to change. And no, it's
Patient
not.
is under local anesthesia, so he can feel a bit of pain. Is that right?
No, so that's why I stopped doing deep venous work under local, and
Okay.
because it used to be very painful, and if you are stuck in some complicated case, and
Yeah.
then patient is crying in pain, and you are not uh, right in the, I don't like it. And
Yeah.
so
But anyway, say thank you to the patient when he awakes.
yeah,
Yeah.
I
It's
think what I
sometimes
did.
when someone difficult step like this, the advantage of local, the patient feel pain if you
Yeah,
are hitting the wall or perforating. So if
yeah.
the patient doesn't feel pain and you're progressing, give you a bit
So
of confidence. But I totally agree.
we have done a small perforation here,
Yeah.
and so which is not very nice to have this. And
It's okay.
yeah.
Problem.
So
You have done a
intervening.
small perforation.
Yeah.
Yes.
Yeah.
So
Small
we will try.
perforation with no flow on it. You just maybe
Yeah,
after a
it's not a
couple of
problem, but
minutes, you try
yeah.
another direction. Yeah.
Okay, we'll try from the other route.
So what you see there is the extravasation.
Yes.
Yeah.
It's a very small one. So roadmap, please. Roadmap now. Yeah. So I'm going to use the other road now. This road is not good. So
So if I got it right, the smooth catheter was in the inferior caval vein.
No. It's in the left common iliac vein, which is the most bad one lesion. So what happens is it gets because of the clot. There are multiple channels. It's a big vein, 20 mm vein. So multiple channels get formed there, and you have to find which is the right one.
Yes.
And because it's difficult to know which is the right channel to go
Yes.
up.
Yes.
And so
Rahul, we need to put a poll question in between.
yes,
but
please carry on. Now do the
Yes.
poll questions, please. Yeah, I am just going to try to cross the wire.
Okay, we can see you while we see the poll question.
Yeah. Please
Yeah.
carry on.
Okay, if we can put the first poll question.
It is already there. This means when performing a thrombectomy for acute DVT, which tips and tricks do you find most crucial for achieving successful revascularization and minimizing complications? So please, please answer. You have like 20 seconds to do so.
That's a very, very good question. Shows a lot of tips and tricks.
Yes.
Yeah.
I think we should now close the poll.
Yeah. We'll see the results. I think most of them will be all of the above. I think. I'm not sure.
ऊपर और ऊपर
Can we close?
Raul,
Thank you.
Yeah, it will take just 30 seconds. Yeah, here is the results. Yeah. 57% of the above. Yeah.
Yes, all of the above, I think, is the correct one. Thank you so much. And now, please, Rahul, the mic is yours again.
Okay, hold please. एक बंदे को बोलो ट्रॉली नेक प्रिपेयर करने के लिए वहाँ पे ड्रेप करना प्लीज.
Excellent. So Raul went to another channel and he bypassed the perforation. He went to another channel and you can see it still none of the dye have reached IPC. It goes to collateral, but he's progressing in the right direction. And this is one of the extremely difficult cases for intervention, venous intervention, really difficult. Because you can't have a road or plan to see where you go. So it takes a lot of experience to know when to push, which wire, which catheter, and when to change and when to do imaging. So it's really superb technique. What other option? He can do crossover from the right side with a crossover catheter, and then he can try to pinpoint the inflow of the left common iliac vein and then try to pass the occlusion from above, one option. Another option to go from jugular approach, because here you have a lot stronger pushability when you go from above. But again, it is usually one of the difficult procedures to do.
And this is very helpful for us to learn.
Yeah, absolutely.
So I have placed a catheter from the right now.
Yes.
And so
yes, you can see he's hooking over the bifurcation. Very nice. Now he's passing the wire from above, but the problem, he doesn't have pushability because when he push, it goes to IVC. So here is a very advanced wire catheter technique to do crossover from above. This is not easy, and this shows how experienced he is in this technique.
But you are advancing, or I?
Yes.
18 ready?
The catheter now is more hooked into the inflow of the left common iliac vein. And sometimes you need rendezvous, you need manipulation from above and manipulation from below and try to rendezvous each other.
So we were not able to get the pushability with the Terumo. So so I'm trying with if we can.
But this is good. You went in.
Yeah, which is
Yeah,
really
he went slightly into the common iliac occlusion, but when he pushes more, the caster take the wire and go to IVC up.
yeah.
And this is the problem with the technique.
Terumo.
Yeah.
And
And this one is a little balloon.
The one from the right side is just the catheter and wire, but from the left is having the balloon and the wire manipulation. And he tried to imagine which direction it is to be in the safest way.
Very interesting. You can see the ureters
Yeah.
pushing urine with contrast media down.
Yeah. And sometimes you need to go from transjugular approach in order to have better pushability in the iliac, so you can have little bit of more force with 6 French and the guiding sheath as well. But it is more difficult. Sometimes, if you cannot pass the occlusion, you go with an out-back catheter outside the vein. You pass into the extraluminal space and you put an out-back again. So you like create it in a new rule or a new road, and then you cover it with a covered stent.
Just for me to understand that, I think you are already where you were with the other one from the other side, or not?
No, it is that 1.3 mm area is not we are able to cross, and that is very tight, and that's the area where we are rupturing the vein.
Okay.
So that's the bad area which we need to cross. And I'm going to do one thing now. I'm going to have another 18 gauge wire from below and try.
Okay. Good luck.
These cases sometimes take 5 or 6 hours to do. And usually we put them on the first of the list, but with an experienced Raul, he's progressing really beautifully.
So we are using a command 18 wire, and this also from Evert, and it's a very straight, a very nice wire, and it doesn't bend, much easier. The tip doesn't get spoiled if it's a very hard lesion. So I'm just going to try this now. So let's try, because now I've got the direction where I have to go. No, this is not the direction. And because I need to go to the direction where my wire already is there. So I don't know where I'm this one.
Now he's using the tip of command 18 wire, which is a nice stiff tip to pass CTO occlusion. But usually venous occlusion, especially of 2 years duration or so, are extremely tough and very, very difficult to pass. They are sometimes like bone.
So I don't know I'm inside or not, but ऊपर जाना wire देखना please. Go up, go up, go up, go up, go up.
This is like a scary movie looking here.
Go
It's
up,
so interesting.
It is.
Yeah,
it
so
is.
I'm looking like I'm already into the heart, guys. Patient
Yes.
Okay, नीचे आ जाओ.
So now he passed
the lesion, yes?
Yes, he passed it, but he must be sure that he is intraluminal, because sometimes you can pass in a space just around the adventitia. So this is the crucial. He's taking every step to be safe that he is in IVC. Sometimes he can use IVIS to answer this question, or a curved caster try to rotate according to which technique he prefer.
Yeah. So we are just going to use a very small balloon, which is not going to harm the patient too much. And so I'm going to use only कितना है? Okay. Light.
But it's an excellent technique for Raul. He made it so simple. And this is one of the most nasty occlusion I've ever seen in iliac vein. It is difficult case.
So we are using a 3-120 balloon, and we are going to use it up and down fish, and so looks like we have crossed the no, ठीक है fish ऊपर. So we have done with the balloon, and I think I'm crossed the balloon now. Yeah. Okay. 10 please. Up fish.
Now he is dilating the occlusion
Yeah.
with
So
the 3 millimeter by
yeah.
20 balloon. This is a small dilatation just to make it channel. So that means if you are not even in the lumen, it doesn't cause much harm. And this is the selection why he selected 3 millimeter, not 7, not 8, until he is sure where his dots are connected.
And
So I'm
now,
just taking a DSA and to see if I'm into the IVC, and it looks like I'm into the IVC, and but I'll just go wire please. No, wire 18.
I didn't see that. I'm too stupid. Can you?
No. It's not very clear because you cannot. It's a very high flow into the IVC. So such a contrast, it was so difficult. So what I'm going to do is I'm just going to change the wire now because I've already made a channel. So I'm going to take the catheter in.
Because the right catheter is far away from the left one. I thought they would join. They would meet in the caval vein.
No. Because the vein is so big.
Okay.
So that yeah. So it gave me a direction, but it may not join up.
Okay. I mean, I wish to you that for the patient that you are in intraluminal.
Yes.
Yeah.
Because my wire has already gone into the heart. So I know I'm intraluminal, but I always just want to be 100% sure.
Yeah.
No. Because of the synechnias, my catheter was refusing to go up. नीचे आना. फिश नीचे आ जा. आप आगे करो. Down please. Down. That's it. Or down. Yeah. So my catheter was refusing to go up. We were stucking into the synechnias. Okay.
Yeah.
Okay, it's gone. Up. Guys, IVC. Up towards you. Oh,
there.
Go up.
Yeah.
If we could, we would do a big applause, and I'm sure that all the audience is in fever with you and with the patient.
No, sure. Thank you. So we are into the IVC. Great.
Yeah.
Wow.
So stiff wire, please.
Excellent. That's excellent.
If you weren't so far away, I would send you every patient with deep vein occlusion.
It's an example of beautiful technique in such a very, very difficult case. Really, really well done.
No, thank you. And so we 6 I'm done. So 7 डाल दो. Okay.
So now we are there, and now we have to make a plan for treatment.
Yeah.
Yes.
But ये वाली wire निकालो. So I'm just doing serial dilatation. So deflate, please.
Do you stent from normal vein to normal vein, Raul, or you had a different technique?
So we are going to do that. So I'm just going to first make the channel so that I never stuck up again.
Yeah.
Because it is because sometimes the wire comes out, because somebody pulls it out. Wire hold, please. Somebody.
Perhaps while you prepare that everything, we can make the next follow-up question. So you have your time to get prepared. Okay.
Yes. That's a great idea. Yes. Second poll question, Khalid.
Following successful endovascular revascularization for DVT, what is your preferred approach regarding long-term compression therapy to prevent post-thrombotic syndrome? So please answer the question. 30 seconds.
That's a great timing, Erika, because this question is after successful endovascular recanalization, which was happened to us.
Okay.
So that is perfect timing.
So Rahul, please wait for us.
Yeah, I'm waiting. I'm just doing some ballooning.
Okay. Some
No.
we can close, I think.
Yeah.
नीचे आ जाओ. अपने उस तरफ करना. Deflate.
Can close the poll.
That's no. Stop, guys. ऊपर लेके जाओ.
Yeah.
The majority of people were the same opinion than me.
Yeah.
Very well.
Okay, inflate.
Thank you so
yes,
much.
that's true.
Okay.
So now we dilated with 5 millimeter balloon, Rahul?
8200 है. No, 60 बहुत छोटा है.
Rahul, the mic is yours.
Yeah, sure. No, so I'm just doing serial dilatation from the top to the bottom now. 6200 or 8200 will be nice. Deflate, please. 8200, 8150. So by the time we are trying to arrange the size, so I'm trying to at least make a small channel in the whole path. Stent, please.
We can ask him which venous stent he preferred to use in difficult iliac lesion.
So we got two venous stents out here available, which are piece niche, which are lesser to control. Niche piece, but that's it. And down, and that's it. Okay, karo. And so we got Optimed, company which is sinus venous stents, and these are dedicated venous stents which we have. Then we got from Atronic and Abre, which is also a very nice stent.
It is two great venous dedicated stents.
And stents, fish, and
at this stage, usually someone gets excited and put a stent straight away. And I usually like to have a good dilatation, inject the flow, make sure that the flow goes all well, and then put the stent in. Because the problem, if there's too much material inside and ballooning was done or haven't done much, then when you put a stent, you don't get a fantastic flow. And this is the problem with putting venous stent.
So just for again, the unexperienced question, you are now throwing back the inflated balloon.
Yeah. So I will put the balloon to maximum diameter, yes, to 10 millimeter, 12, or even 14 millimeter balloon. Then I will check the flow.
Yes.
Check if there is nice flow, then I will put a stent. But if I don't have a good flow, putting a stent will not create a flow. This is different from arterial.
Correct. Understood.
Yeah.
Absolutely. So absolutely right, because we have done basic ballooning, and we are trying to improve the inflow from the popliteal vein up to the popliteal vein. Deflate, please. Down, please, little bit. And I'm going to do little bit vein and yeah.
Now ballooning up to the sheath, and this takes multiple procedure. The beauty is that when he injects a dye after this ballooning, the small perforation in the beginning will not be seen at all. You wouldn't see anything because now there is a good flow to IVC. So and usually when you do it under local, patient feel immediate improvement in his leg. If you done it under local, at the stage you do the balloon dilatation, he feels that the pain and the load and the heaviness have immediately went down once we done the ballooning.
Yeah.
But so we usually do it under general.
Absolutely. So we have done the 6 mm balloon throughout, at least made a channel where we have. Now we're going to do the iliac vein with a bigger balloon, maybe a 12 mm balloon. And so can I have the sheath, bigger sheath, please? So I'm going to change the sheath size because it will be difficult to cross the balloons from this sheath, and I'm going to put in a 10 French size sheath size because the easier, because then I can, even if I have to put in stents, need okay. So even if I have to put in a stent, they all go from this. So it's a 10 French sheath which we have put in, and it can easily can take up all the stents, both Medtronic and the other ones. So it's easier for us to take the things. So let's put in a bigger balloon into the iliacs. Push little bit up, and up little bit. That's it. So I'm just going to
It's a
take.
fantastic demonstration of passing one of the most difficult electrocution, Rahul. Congratulations, really.
Thank you. So we can see the flow in the main vein has improved little bit, just with the dilatation with 6 mm, because it will require prolonged dilatation with an 8, which I'm going to dilate later. Up, please.
Yeah.
But at least some improvement is there. Piyush,
Yeah.
up, please. Common femoral vein.
The problem with the vein that
Common
they
femoral
do
vein, please.
recoil. So even if you done good balloon dilatation and you try to inject, you find that the flow becomes minimal due to the very tough recoil.
That's it. Yeah. So I'm just going to see how much it has improved into the femoral profunda, and how is the inflow, to make a small decision in my mind. Will I be doing the stent or will I not be doing the stent? Because if I have to do the stent, I have to come up to this point. And you can see up to the lesser trochanter I have to come. What is the size? So I'm going to dilate roadmap here, please. So now I know up to what point the inflow is.
Yeah.
So the profunda always come at the level of the lesser trochanter. So I know this is a sort of a common femoral vein area. So I'm going to take this balloon up and do this, start doing the ballooning from here. And so it's a 12, which is good. Up, please. So this is a big balloon. Photograph, please. And so we have opened up the whole balloon, and deflate, please. So we are going to do this and make a channel up to 12 mm now, and up to the top, and then see how we are. Okay, please. So normally up to 12 is okay in the common femoral and iliacs, and so we can see the Seneca and the things which are getting broken up on the side. More up, more pressure. Yes.
Is it possible? Is it possible to break the vein wall with this?
Yeah, it can, but normally because we are through the vein, and we knew the lumen which was there on an angiogram. That's why I was doing an angio and going up. So normally, if you are in because it's a chronic vein wall, so even if it's a small rupture, it doesn't matter. It heals up, and normally at 12 mm, these veins, they don't rupture. Deflate,
And
please.
how much pressure do you have to apply with the hand when you are filling the balloon? I imagine a lot.
We are doing this is an inflation device.
You have a device, yes.
So we use an inflation device. It's we don't have to use any pressure at all, and so it's an automatic machine.
But I imagine that it needs a high pressure.
No. So can you see this now? And it's opening up now, very tight lesion. So this was the area in the beginning where we got stuck up, where the catheter was not going up.
Yes.
Where we used the balloon. So it was very tight. So we are able to open it up now nicely. Please go up, please, a little bit. And so we just making a channel. We don't want to inflate it like an arteries for a very long time. And up, please. And so can
you
you see
face
this
situation
very
of
tight
ruptured
lesion?
balloon?
Absolutely, keep on going up, high up. How much is the pressure? 6, 8, 10, 12. Okay, deflate, please. So now when we go up, then you will see it's so tight, it will be very difficult to open it up, but we will see, we go slowly. Okay, up please. And so now you can see how tight it is, and how the balloon is opening up. And with the, so I try to go at least with the 12, I'm very okay with to have the smooth walls on the side. And because the balloon has to open up nicely, because then only the stent will go inside. So we have done that now, and going to go up little bit now. So this is the worst area. Push niche, you're gone too up. Yeah, and 12 up. So up, please. And so we go. This is really nice. So this is the worst area, which is a common iliac vein, which we were worried about, and which has really opened up nicely. Okay, open up, please. Close. So I think another one area I'm going to go and cross and do the inflation.
You think most of the cases one pass inflation is enough, or you like it to do 2 or 3 times?
No, one because I'm just creating, because with the balloon, and when, all these veins, they don't open up. So the moment I'm going to take an angiogram now, is going to show nothing. It will show that because all these veins are chronically inflamed when you open them up surgically. So they don't open up like an artery with a balloon. So the moment you deflate the balloon, the vein collapse. Same.
Yeah.
So it's a very fibrous tissue, old fibrous tissue. So they don't open up like that. And so if we have to open up, we have to put in a stent. So what I have done is, I'm just making sure there is enough space for the stent to land and be there, because sometimes if you don't do this pre-ballooning, when you open up the stent opens up in pieces, the dedicated venous stents. So you are not able to pass the balloon through the stata. So it's very difficult sometimes. You get really stuck up. Okay, so we are going to remove the balloon now, and careful with the wire. And we'll take one venogram now, see where we are, and one venogram from the right. And then we make a decision, should we do the stenting or not? Okay, hold this.
Would pressure measurement across the lesion of the occlusion will be helpful in your decision making, Rahul, or not necessarily?
No, not with the pressure. No. Push, no. Center, push. We want to see both. Yeah, that's it. So what we have done is, we are going to look into it. Contrast, please. So we got it in the center, and slowly करना. हाँ, तभी करना. नहीं, बदल, please, ठीक है. Okay, so I'm putting in a contrast from below, and see how the flow is. Does the contrast comes there or not? It's coming only through the collaterals, and we have put in the contrast on the opposite side. So it shows there is no opening of the veins even after ballooning. So if we have to, no, that's not, close. And so we are going to do it from the top, the stent up to the bottom. Now I'm going to see the inflow before I make a decision, and then we're going to think about it. Go down, please. Down, and yeah, forward.
The last injection was from the popliteal venous sheath.
Yes. And
Okay.
so now I'm going to see how the flow is, and make a decision now. Should we have a good inflow from below or not? Because what has been shown is that if you don't have good inflow, then all these stents, they don't work at all. So we got a good inflow from the profunda, but not from there. So can I have an angle, please, on the other side? More. That's it. That's it. Fixed. Okay. So what I've done is I've done a lateral angle so that I can have a profunda separated from the common femoral vein very nicely, and you can see a very good inflow from the profunda, but not a very good inflow from the common femoral vein or from the deep femoral vein. So, now the decision is, should we leave him alone here, or should we put in a stent from there up to the superficial femoral vein? Because, or sometimes people go into the profunda vein to put in the stents here, and put in like the top stents we put in first, and then we puncture the profunda and we bring the stent into the profunda vein. So now that's a question we need to discuss now, all of us, and should we do it or not? By the time we discuss, I'm going to dilate the deep femoral vein with a 10 mm balloon.
For me to understand,
10 mm.
you are sure to make the stents from the whole section of the iliac vein. This
Yeah.
one will be stented.
Yeah.
Yes, and you are questioning if the inflow from the profunda vein is enough, or are you
No,
going down? Are you going down to the superficial femoral vein? I mean the femoral vein. Are you?
Yeah. See, what happens is the inflow is only from the profunda.
Yes, but because the
So
other one is closed, you could also stent it or not.
yeah, so but we can't bring it stent up to the popliteal,
Ah,
So
correct.
so either we I'm going to do this ballooning of this uh, this 10, right. So we are doing the 10 mm dilatation with the balloon in the whole deep femoral vein and see deflate.
You mean
I
in the
like very much, the decision-making process of Raul, because in arterial cases, once you pass the wire, that's it. You just put a stent back home. It's easy. Everything is inflated. In venous, it is not like this at all. Sometime, which I think, if you have an inflow to the groin from profunda and remaining of femoral vein, which is low, whatever stent you put, it will not have a flow. That is why we used in the old days to put an augmentation AV fistula to increase this flow. So he is very wise, because the worst scenario is to put a stent, long stent, and to have injection venogram, no flow in the stent. This is the worst scenario that we want to avoid. How we can avoid this? By multiple decisions across the way, as Raul is doing. So it's a fantastic way of having a strategy toward venous stenting, which I am enjoying very much.
Down, please. So basically, so I'm down, please. Piyush, machine पे कोई आओ. Deflate. Okay.
Maybe what I would do, maybe a bit different, is put a catheter near the femoral vein at the groin, and from this area inject a dye and see how rapidly it flows to IVC. Because if I can get this segment patent, usually patient improve. But because he's injecting from the popliteal vein, 50% of the flow go to profunda, the other 50%, but the time it reaches the groin, become very, very weak, wouldn't give you an idea about the iliac vein filling. So this may be what I would do a bit differently. But other than that, the cautious approach before putting a stent is definitely sound experience.
If I don't achieve the good inflow, then I will not put in a stent. And in my, there are a lot of times I leave the stent because there is no point what you are saying. I put in a stent and then there is no flow through the stent. And so,
Rahul, would it help you if we just leave you 10 minutes, do a presentation and come back to you. In the meanwhile, you have decided that punctured or whatever, because time is a bit running out. Is that okay?
Yes,
for
so
everybody?
let's do the presentation now, because it will give me 5-10 minutes to make a decision, and then we'll see.
We come back to you in 5-10 minutes. Is that
Yes,
okay
please.
with everybody?
Yes, please. Perfectly fine.
Yes, thank you, Rahul.